All right. Hi, everyone. Welcome in. I'm gonna give a few more minutes for people to trickle in, and then we can go ahead and get started. Right. So we can go ahead and get started. Hi, everyone. My name is Jayla Stewart. I am so happy to be with you all today on the second part of our webinar series, The Basics of the Gold Standard for Treatment. So just the agenda, welcome and housekeeping about Unshame North Carolina, webinar overview. We're going to have the speaker introduction, of course, the presentation, and then leaving room for question and answers. But as you trickle in, please feel free to share your name, your organization, anything you would like to share. Please feel free to put that in the chat. We're super excited to have you here with us. Before we get started, this session is going to be recorded and we will have a copy of the presentation available on our website, as well as if you want a certificate of attendance available upon request. We ask that you come in muted, but please use the Q&A button at the top of your screen to ask questions. The chat is also available for you to put in any questions or reflections that you might have. To access closed captioning, click More, select Language and Speech, and then choose Turn on Live Captions. And then you can also adjust your speaker view to see all of the speakers at the same time. I also want to thank Angela and Heather for being here with us today and doing live interpretations for us today. So thank you for being here with us. So, what is Unshame North Carolina? So, we are a statewide campaign led by the North Carolina Department of Health and Human Services in partnership with Shatterproof, which is a national nonprofit. Our goal is to remove the stigma around substance use disorder through a community driven approach focused on awareness, education, and uplifting the voices of lived experiences. So our campaign works by partnering with communities across North Carolina to reduce stigma around SUD through education, storytelling, and resource connection. We do this by sharing lived experiences, science-based information, and we really are focused on building understanding, compassion, and pathways to care, so more people feel supported seeking help. How do you get involved with us? So you can join us becoming a coalition member. So that is our partnership. Please feel free to join us. I will share a QR code in the next slide. You can join our coalition. We have coalition meetings where we come together as a community and just talk about different things going on with the campaign, as well as what you're doing in your organization. Amplify the message. We really love lived experiences and sharing those lived experiences. So please feel free to share your story or promote that. And then follow us on social media, Facebook, Unshame North Carolina, and then Instagram and YouTube, Unshame NC. And then this is our QR code. Please feel free. This goes to our link tree, so it will take you to our social media, our newsletter sign up, our interest form to be connected to story sharing or the coalition. All right, diving into the purpose of our webinar. Why are we here today? Dr. Shukla is going to take us through the science behind MOUD, including how they work and why they are safe, effective treatments, understanding the different types of MOUD available and those benefits, and then exploring the availability of MOUD in North Carolina and the importance of expanding access. And we just like to put this blurb at the bottom, whether you're new to this topic or looking to deepen your understanding, this series is designed to help anyone who wants to get that better understanding. Right, we are super honored to have Dr. Shuchin Shukla here with us. Dr. Shukla was born and raised in New Orleans, Louisiana. He completed medical school and public health school at Tulane University and completed a residency at Montefiore Medical Center in the Bronx, New York. He is board certified in family medicine and addiction medicine. He has served in leadership positions related to population-based projects focused on overdose addiction, HIV, hepatitis C, and carceral health. He now works as a consultant for the North Carolina Technical Assistance Center, a state-funded consortium focused on overdose and addiction among people involved in the criminal legal system. He also serves as Chief Medical Officer for Goldie Health, which provides case management software for post-overdose response teams, and as Medical Director at Greenville Comprehensive Treatment Center and Opioid Treatment Program. We are super grateful that Dr. Shukla is here with us, and I am going to pass it over to him. I'm going to stop sharing so he can go ahead and start sharing.
Great, thanks, Jayla, for that kind introduction. Can you all hear and see me? Cool. And do you see my slide now, or am I sharing? It should be. Oh, I think I have to click this, bring content on screen. Oh, you did it. Thank you, whoever did that.
Yes,
excellent. Cool. So welcome, everyone. That's great, Jill, that you said the learning objectives, because then I don't have to do that. I do just want to plug the NC TAC, North Carolina Technical Assistance Center. We have a whole lot of experts besides me on the team, including current and former law enforcement who also focus on harm reduction. We have harm reduction workers, overdose prevention folks, public health folks. So a variety of areas of expertise. That QR code brings you to our website where you can request a free TA or training for your agency or for yourself. And there's also tons of webinars and resources going back years. And we have a cool mailing list, so please check us out. I'm going to skip the objectives. I do have a handful of slides that sort of remind us of what was covered in part 1 of this. This is part 2, and that is on the Unshame website. And if I'm wrong, Jayla will correct me in the chat box. But so if you didn't see part 1, that'd be great. You can see it after the fact because you can't do it now. I'm doing part 2, but that might give you a grounding for what we're talking about today. That one focused on the basics of substance use disorder, particularly the brain science behind it. But here I'm going to review a few pieces of that because it really speaks to how and why medication works the way it does for opioid use disorder. And though I don't remember now, but in part 1, I think we talked a little bit more broadly about substance use disorders. In this one, we're really going to focus on opioid use disorder and opioid use disorder treatments. So this graph, which is one of my favorites, because I can see in the participant list, a lot of people I know have seen me speak, so I've seen my slides a lot of times, but this is a good schematic of how someone who may start using an addictive substance, in this case opioids, how they may get caught in a cycle of recurrent use. And this is, again, important because treatment needs to address these primary reasons people continue using things like opioids once they've sort of started. And it might take days or weeks or maybe months for someone to get into this cycle. It's not really easy to predict who will have a dependence and be unable to stop. But there's 2 things that really drive this. Isn't there a way I can have a pointer? Yeah, there we go, laser pointer. So cool, you see my laser pointer. So here is a person maybe using prescribed opioids. They take it and it improves their mood almost as a side effect. It wears off and they go back to normal. The up and down on this axis is feeling good, feeling normal, feeling bad, anxious, dysphoric. And so you're up and down, and over time, the thermostat changes so that the peaks aren't as high and the valleys or the troughs are lower than your normal, such that, and for those of you who drink coffee or use a whole variety of substance, you can empathize that you need higher doses of the thing over time to get the same effect. Or if you were to stay on the same dose, you would eventually only feel normal on that dose. So if you're used to drink a cup of coffee every day, 1 cup of coffee doesn't work like it did the first day you ever tried coffee, right? So that's the peaks here, and that's tolerance. You develop a tolerance to caffeine, or in this case, opioids or fentanyl. And then the troughs, the bottoms of this, instead of returning to normal, your normal now is feeling really bad. And so it's pretty common for someone who becomes addicted to substances such as opioids that they use to feel normal. Clearly, people like to feel good. And if you can feel good, that's great. But they use at least to feel normal, because when you're not using, you feel really sick. And that's this first half of this. But let's say someone goes through their period of withdrawal. We'll talk about that in the slide here. But and they're done with their withdrawal. The second thing that causes people to continue using drugs like opioids is cravings. And that's reflected in, cravings can be from a lot of things. It can be from positive experiences. I have patients that tell me when they get paid or they have money in their pocket, that's a trigger for them to want to use, even if they haven't used in a while. Or they see substance use on TV or whatever, or they see a friend that they used to use substances with, et cetera. Or it could be, in this case, a life stressor, like something bad happens, you have a stressful day, you wake up on the wrong side of the bed, a whole variety of things. And in people who have developed a substance use issue, that life stressor can be the trigger to cause them to want to use again or return to use. And sometimes we use the word relapse or return to use. And this isn't just like thinking or like, we used to say, oh, it's all in your head, or, I'm sure someone said that to me when I was a kid, but truly it's all in your head in terms of it's biologically in your head. These are changes in the brain that reflect both the changes in the peak, the intoxication, which is your nucleus accumbens, this blue part of the brain on the right, the changes in the amygdala and some parts of the brain involved with withdrawal and negative affective states. That's closely related to your stress hormones, your adrenaline hormones. So those are ramped up over time. And in between, the cravings is changes in the hippocampus and orbital frontal cortex, so parts of the brain involved with thinking, preoccupation, anticipation. These changes happen at the macroscopic level, so you can see this on MRIs. If you were doing a dissection of a rat that was made to become addicted to a drug, you would see it in changes in like actual volume of brain regions or connectivity of neurons in those regions. And you would see it change over time. And then on the left side, you can see that's some cool drawings to show the changes that happen at the microscopic level. So the actual way nerves talk to each other in these brain regions change. Has to do with how much of a neurotransmitter, which is a signaling chemical between two nerves, how much of those chemicals are released, how many receptors, which are the lock for the key there, are expressed on the receiving neuron, and the connections between the different neurons. All these things change. So those feelings aren't just feelings in the way we want to dismiss, right? That was the part one, was all about the brain disease model of science of addiction. These are actual biologic changes. I would say similar to the way we see pancreas changes for people with type 1 or type 2 diabetes, or heart changes with someone who's had congestive heart failure develop, etc. So this is biomedical condition that works closely with changes in behavior and thinking and feelings. And just to kind of review, this is sort of a graph of how that withdrawal, that first half of that previous graph, develops. For some people, it might be 4 to 6 or maybe 6 to 8 hours after last use of opioids, where they start developing these symptoms. And as I said in that first session, these symptoms are, over decades and maybe actually centuries. Very famous poets that I studied, in grade school and middle school or whatever, in the Norton Anthology of English Literature, they wrote about, opioid withdrawal, right? Amazing rock music and popular music is written about how terrible an experience it is. So physical symptoms at peak, and they listed out, that's just like not really doing justice to the excruciating torture of opioid withdrawal for many people, literally leading people to suicide or to really do things that would be usually not in their normal interests in order to not feel that way. And that, peaks around 2 to 3 days. It lasts for maybe a week or two as those physical symptoms subside. But as you can see, 1 month and longer, you still have these cravings and mood changes that can last for weeks or months. and really contribute to return to use. So that is addressing the one category, and sorry, I'm looking over here because actually I can look over here. I see my slides everywhere. Um, that's contributing to this one section of what is the definition of a substance use disorder diagnosis, the physiologic, which is that tolerance and withdrawal, as well as the cravings, which is the lack of control. It's changed your ability to control your behavior because of the changes in your brain from your ongoing use. So treatment has to address the physiologic. Treatment's got to address this lack of control, which is again in the brain. And it also has to address the risk and harm, which I'm not going to read this, and you can certainly get a copy of these slides, I'm sure, one way or another, or you can just Google DSM-5, the criteria for diagnosing an addiction to a substance. But the risk and harm is really important because, as I think I said in the first session, any medication or even food in human life can be something that hurts you. People can overdose on caffeine and die. People can literally overdose on water. It has happened. You can Google that. Often marathon runners who drink a lot of water without solute, they can have a pretty dangerous brain condition. So any medication, fentanyl is, as I say frequently, my wife got fentanyl in her epidural for at least 2 of the pregnancies. So that's a common medication. Just because it's fentanyl doesn't mean it's bad. It's more about the context. And so treatment has to address that. We're giving treatment in a way that reduces risk and harm and doesn't increase it, just like I do for all the things I prescribe, whether it's insulin or HIV meds or, heart disease meds. It's also important to understand how treatment with medication works in the recovery timeline. So I won't go over this on the left, but the short story here is that, people usually try to get better on their own when it comes to addiction, often for years before they maybe start seeking help. I think that timeline is probably even shorter than it used to be because the drugs are so much more dangerous. And so crisis episodes often bring people to the attention of the system, whether healthcare or criminal legal. And then people will have multiple treatment episodes, often with some treatments that are less effective than the medication, to be totally honest. And then, after that, they achieve, some remission. Relapse is very common. But after getting to at least 5 years of no use of that substance, is their risk of relapse back to like general population. So I wouldn't say they're cured, but they're back to a normal baseline risk, like we all are at some kind of risk. And the important thing to recognize is that timeline often follows sort of how this pyramid demonstrates the stages of recovery. So this is the timeline, but this is the stages. And I think one misconception that I'm hoping to address in this talk is that a lot of treatments, whether the idea of treatment from policymakers or parents and family concerned family members or friends, or law enforcement or people with power and authority who make decisions on my patients, they often think of the top half of this, which is, yeah, you need to talk to a therapist about your stuff, and you need to just get away from the drugs, and you need to get a job. And yes, that stuff can be helpful, but that's sort of the early, middle, and late recovery stages. The hard part is that people need to address the beginning, and the beginning is the stuff I described, feeling withdrawal symptoms in the next 6 to 8 hours. So if you're going to get sick in the next 6 to 8 hours, unless you use drugs, it's hard to think like, well, I'm going to make an appointment for a therapist, and that's probably 3 months out or whatever, but then I'm going to go to a job interview, and I'm going to like reconcile with my family so I can find some stable housing. It's like, whoa, we need to stabilize, develop motivation, and then have immediate reductions in harm and risk to improve immediate physical health and mental health risk before we get to the deeper layers. So here today, I'm really focusing on these first 2, or really the stabilization stage of this, where medication really plays a role. Because just to point out, the first stage there, transition, that's my peer support, friends and cousins. And then these upper stages are like counseling and housing. And I mean, housing can come anywhere here, but I'd say the counseling and kind of working through your traumas if and when that's appropriate for you. For a lot of people, it might just be getting past stabilization, because certainly your mortality risk and risk of harm and death is very much decreased after stabilizing. So let's talk about treatment options. So Medications are very, all caps, effective and safe. Lots of research to prove it. It exists. Medications for addiction exists for alcohol use disorder, very safe and effective. Nicotine use disorder, safe and effective. And opioid use disorder, which we're going to focus on. And as I said, without medications, many people will feel extremely sick if they stop using their substance. And so they cannot stop. And even if they stop, the brain is changed and they will have cravings. Those are not permanent brain changes, but they aren't short lasting either. It takes time. And usually the risk of relapse happens, affects them before their brains can go back to pre-drugs. So talk therapy can help, as we talked about, but that's a little later down the line. And then reducing the harm of using substances, making it safer, can help a person be healthier even if they continue using substances. So that's applicable at all stages of a treatment plan. Using less, even if you don't stop completely, eating healthy, staying hydrated, getting enough sleep, that literally will improve risk and harm, even if someone's using safe housing. And then, using alone is dangerous. So using with someone else who can spot you and get help for you or resuscitate you with naloxone in the case of opioid overdose, that's really key. So how'd I do on time? I don't know. Okay, so we're going to talk about medication for opioid use disorder. This is going to have some technical sciencey stuff. So, take another sip of your addictive coffee so you can pay attention. So here's your brain schematic. People keep using opioids like fentanyl or heroin or Percocets or whatever because those opioid receptors are used to getting that. And without it, they go into withdrawal. And so there are 3 FDA-approved medications for opioid use disorder. Methadone was first approved in the U.S. In the late 50s. I know, Anna, you're on the call, so you can correct me in the chat box if I'm wrong. Late 50s, 60s. And so we have, 6 decades plus of research to support methadone use, old school, works well. Buprenorphine has been around since in the US for addiction treatment since about 2002. So we have decades of evidence of how that works, which I'll also be talking about. And naltrexone, the injectable form of that, which is what is FDA approved for opioid use disorder. It's only been around for 5 to 10 years. And you can see the cute little graphic shows 3 kind of different ways that fits on the receptor, and that is really pointing to something important, which we'll talk about. There are 2 main ways of getting these medications in America. It's different in Canada, different in European countries and elsewhere around the world, right? So this is has to do with our DEA and FDA and et cetera. But 2 ways. One is through opioid treatment programs. Sometimes we call those methadone clinics. And those are regulated by multiple federal agencies, multiple state agencies, and in some ways county agencies, with zoning, et cetera. The second place to get treatment is what we call OBOT, though many people don't refer themselves as OBOT, but that's office-based opioid treatment. So let me talk a little bit about those. Both programs utilize things like drug testing. Both involve prescribers. But let's talk about OTPs first. This is the only possible place in the US to get methadone treatment for opioid use disorder. If you're getting methadone for chronic pain, you can get that from the pharmacy. But with OTPs, the methadone is either administered or dispensed, meaning the nurse gives it to you the way they do in a hospital. They watch you take it, or it's dispensed where the pharmacy is basically in the clinic. They give you take homes and you go home with it. It's never prescribed. You don't get a prescription for methadone and go somewhere else to pick it up like you would your blood pressure medicine. You start with observed daily dosing so that you go and you take your medicine, you come back the next day and repeat. And usually Sundays you get a take home. But over time, as that dose is slowly titrated up to the right dose for you, you start stabilizing and then you start getting take homes. And that can happen sooner than it used to because of rules that changed because of the pandemic. The titration of this dose has to happen not too fast and not too slow because the medication has some specific pharmacology, which we'll cover in the next slide. At these OTPs, you can also get buprenorphine, which is the second medication I mentioned. So you can also get that in that same way of like daily dosing and you start getting take homes. At these clinics, in general, regular counseling is required, and there's a couple other requirements around drug testing and paperwork and things like that. And we'll talk more about OTPs in general in North Carolina. So the next place, site of outpatient care is OBOTs, as I mentioned. This can be pretty much at this point in American history anywhere, and anyone who has a DEA number can prescribe this medication. If you can prescribe an opioid, you can prescribe buprenorphine. Counseling is optional. You don't have to do it. And because anyone can prescribe it, it's often integrated with other health services. So your family doc, which I am one of those, can prescribe it. Your psychiatrist can prescribe it. Your OBGYN, your midwife, your nurse practitioner, hell, your dermatologist could technically prescribe this if they have a DEA number. So many types of providers can provide this. And we'll talk about why those rules are different with buprenorphine in here in a second. And then I didn't put it on the slide, but naltrexone is not even a controlled medication. So like, even if you don't have a DEA number, you can prescribe that. But because it's injectable, you sort of have to figure out the logistics around that. So let's talk a bit about how these medications work. Methadone, we'll start with that. Let me orient you to this graph on the right. So on the left and right is the dose. So going further to the right is the higher the dose, right? And it's just arbitrary, but more dose, more to the right. The up and down is the effect of the opioid on the receptor. So if you can imagine, and this is the line where you might start feeling the effect a little bit. This is the line where you're feeling a little bit more. This is the line where you're feeling it more. This is the line where you're starting to feel sedated and slowed down. This is where your breathing slows, and this is where you might overdose. But for people who are used to opioids, remember the thermostat has changed. And so in that case, this middle area is where they might feel normal. It's very similar to that previous graph I showed. So this is their normal. This is down here feeling dysphoric. I'm going to make a sad face. It's hard to do it with the mouse. And then this is I took too much face, which is not a good face. So the way methadone works is it is a straight line. It is a straight line. The more you take, the more the effect. It works in a way like fentanyl and heroin and oxycodone and morphine works. The more you take, the more the effects. And so if you take too much, it can hurt you. So why would we give this for treatment? Well, because just like people who use opioids illicitly are trying to do, we're trying to get them in this happy middle. Because in the middle, they're not sick, which is down here. And up here, they would be not breathing and potentially at risk for overdose. We want them here because then they won't use fentanyl or other opioids to improve their withdrawal symptoms. Because methadone has a slow half-life and metabolism, we usually start low at a certain dose and slowly increase it. And by slowly, I mean we make a dose change every day or 2 or 3 or 4, depends on several factors, and slowly increase them until we get them up the path to this middle area. I can't do a blood test on you. I can't ask you a specific questionnaire to know what is the perfect dose for Heather, the interpreter. I see your face. I'm using you, Heather. I can't do that with anything besides, in a way, trial and error. In general, I have a sense, right? Like if someone's injecting a certain amount of fentanyl every day, that's going to be a person different than a person who's ingesting, oxycodone pills from a pharmacy where I know what they're getting. But in general, I kind of have a feel, but also in general, I've seen little old ladies who need really high doses. I've seen huge hulking men who need relatively low doses. So you start low because you don't want to overshoot. That's dangerous. But you also have to be careful not to undershoot because then someone's going to keep using fentanyl. And continuing to use fentanyl or other opioids is common in the beginning because, again, they're having cravings and withdrawal symptoms down here until we slowly bring them up. Oh, sorry, there's my laser pointer. So as we slowly bring them up to get right here. Methadone does have some sort of side effects that we worry about besides just being an opioid that causes all the normal opioid side effects. It affects your hormones to a certain extent. It affects, your bone density over time, et cetera. It also has some drug interactions with other medications, and it has some heart rhythm, rare but important heart rhythm issues that we can screen for with heart, some heart tests like an EKG. So let's contrast that. So in the way this works is you get someone up here, they just stop using, right? Because now they're not feeling sick, so that stops them from using, and they don't have cravings. The dose that gets them there, that therapeutic dose, which is different for all people, is what stops them from wanting to use opioids for those two reasons. Let's compare this to buprenorphine, the second medication. It is different. Remember, it was Dippin' Dots on the receptor instead of that perfect key in the lock on that graphic. As you can see, this blue line is different. At a certain point, no matter how much more of the dose you take, you get a ceiling effect of respiratory depression. So even if you don't, yeah, there's my drawing. So even if you go beyond the dose with methadone, if you kept on going up on the dose, you would get in trouble. But with buprenorphine, even if you keep going up on the dose, for that respiratory depression, meaning slowing your breathing, it doesn't work any stronger. And thus it is inherently less dangerous. Because if you take too much, you're at much less risk, not zero risk, but like less than some over-the-counter medications, to be honest, less risk of getting hurt. There's caveats. Let me just say, like, you can get hurt on anything. Like you can drink too much, like I said, water and hurt yourself. So no one go try it and say, Dr. Shukla said I could just do whatever I want to do. Don't hear that. Don't do that, please. But it's much safer. And this is why the experts of the world of America have made the decision that this is something you get from prescriptions where you don't have to have that daily monitoring necessarily. Because if you do something wrong with the medication, take it all at once, let's say, because you have an opioid use disorder, you have trouble with self-control over, something that's in front of you, well, then it's not going to be as harmful as it would be with methadone. Both medications have a long enough half-life where you could generally just take it once a day, though some people need it more than, need to split their dose into like half in the morning, half in the evening, let's say. But both work similarly in stimulating those receptors so you don't have the cravings, you don't have the withdrawal symptoms. This thing with the affinity, I'm skipping over weak affinity versus high affinity. It's a little like next level information, but it's basically how you start the medication is a little more complicated with buprenorphine than it is for methadone. And I think that's more important for clinical providers. But it does make buprenorphine a little harder because you have to be off of opioids for a certain amount of time. And that might be 12 to 24 hours before you can start buprenorphine. Whereas methadone, you can start as long as you're not, sedated, intoxicated, kind of falling asleep. As long as you're not at, like at that level, you can start it even if you spent like an hour ago or 2 hours ago. So that's another big difference. So the last one I'll talk about is naltrexone. A lot less evidence behind it, and we're going to mention some of the evidence behind how it works. But keep an eye on the time. It does not affect the opioid receptor in terms of stimulating. So it doesn't work like bup or methadone or any other opioid because it doesn't improve your withdrawal symptoms. It doesn't improve your cravings. It is more like if the other two were different types of keys that turn the lock, methadone opens the door all the way, buprenorphine opens the door half the way, let's say. Naltrexone doesn't open the door at all. It's just glue. It's somebody that put glue in the lock so nothing else can get there. So the idea is you take naltrexone, and if I took my naltrexone this morning and then let's say later the next day, I wanted to use opioids and I took a bunch of oxycodone, well, it wouldn't work. It wouldn't get to the receptor because the naltrexone is blocking those receptors like glue. It will take opioids off the receptor if I already have it in my system. And so you have to be off opioids for the injection for 7 to 10 days before you can take that injection. And that is one of the biggest problems and barriers to using this medication. But the second thing is it doesn't help with withdrawals and cravings. So people will still have to go through that withdrawal for 7 to 10 days. And they'll also have cravings for however long that might last, which might be weeks, months, or even longer. So there may be questions related to this, and please put it in the Q&A, and I'm going to do my darndest to make sure we save time for that. But I'm going to keep on moving because that's the hard part. So how well do these medications work? Let's start with the bup and methadone because a lot more research behind that. And, there's levels of research. There's research where you just observe what's happening with two groups of people. That's observational trials. There's research where you do something. You say, I'm going to do something to this group and that group in a controlled research setting and not let anyone know what they're getting. So you get your placebo pills in one group, et cetera. And that's more like a randomized controlled trial. And then above that is let's pick a bunch of randomized controlled trials in different settings with different people groups, young people in the Southwest and older adults in Antarctica, or, like you take different groups in different settings and you put it all together with advanced data analysis. And that's sort of the highest level of research in American Western medicine, Western science. So that level of research has been done on methadone and buprenorphine. And this is one of those studies, and I have a citation there at the bottom, but I can't even read. Oh, there, I can read on this side. So here what they're showing is on the bottom is the different outcomes. All-cause mortality means death from any cause, and then you have death from specific causes, kind of breaking it down. And then you have death, all-cause death for people while in jail and after jail who have a much higher risk of overdose death than the general population. The dark blue, is it coming dark blue, is off no meds, no methadone or buprenorphine for people with opioid use disorder. And the lighter blue is with it. And this is the relative risk of overdose or of all those outcomes. And so you can see here, the most important thing to me as a doctor is death. And me as a human on this planet is I don't want to die. I love my family and kids and the sunshine and the rainbow. I love things. And you can see here it decreases the risk of death by 53%. And let me pause on this. Okay, so my background is as an HIV doctor, a hepatitis C doctor. I've delivered babies. I take care of the young, the old. And I can tell you there's really nothing in Western medicine already that works as good as that decreases your risk of death, within days of taking it or within a week or two of starting it, depending on methadone versus bupe, that decrease your risk of death by 53%. It is that quick how effective it is, and is that effective. And so I'm not going to read the rest, but you can see that's why graphs are so good. Use your eyes to see how much it decreases risk. It is not a treatment for alcohol use disorder, but you can see it decreases alcohol mortality and part in these other mortalities because these are all tied to people using substances and having cravings. People drink because they have cravings. They commit suicide because the withdrawal is so bad. They develop cancer because they share syringes and needles and develop hepatitis C or B and develop liver cancer, or because they're using other substances and develop, esophageal cancer, stomach cancer, et cetera. And then especially because the risk is so high for overdose during and after incarceration, using the medication is 94 and 91% effective, or 91, 94% decrease in risk of death for those groups. That is a miracle medicine, and why, I love babies. I want to deliver more babies if I could, but I'm devoting my life to this work because of how effective this is for such a big problem in our country and in North Carolina. What about naltrexone? So these systematic reviews and meta-analyses, high-level research has not really been done on naltrexone because it hasn't been around long enough to do the trials to get to that level of research. But of the trials we know that it doesn't work so great if you're taking it. So here we have this one kind of trial that's looking at buprenorphine, comparing it to Vivitrol with it, which is the injectable naltrexone, and then ultra naltrexone, which is not even FDA approved for opioid use disorder, and then no medication at all. And so blue is on treatment, and you can see, it's better than no meds, and buprenorphine is much better, and oral naltrexone is actually worse than no meds. But when you are off the meds, which a lot of people discontinue it because it's not, again, helping with their cravings, and actually a variety of reasons people discontinue medication, you can see the risk for buprenorphine within 4 weeks of discontinuation. Sure, it goes up. Your risk of overdose goes up, but the risk is much higher with Vivitrol. And the reason for that difference is both groups are using drugs when they, within 4 weeks, or have the same risk of using drugs within 4 weeks because both the medicines worn off. But the folks who are on buprenorphine have developed a tolerance to opioids that's maintained by the buprenorphine or by the methadone. Whereas if you take the Vivitrol or naltrexone, you have no tolerance. That's the whole point. It's taking away your tolerance. It's blocking other opioids from creating tolerance. So if you were to use that same drug and came off of bupe, you have some risk. But if you were to use that same dope, I'm using the words patients use, if you were using that same bag of drugs, your risk is so much higher because you don't have tolerance. And so it's actually quite dangerous, literally, to even put someone on Vivitrol unless it's right for them, which is a complicated conversation that has to happen between a provider who knows what they're doing and a patient who can understand the risks and benefits of the different options. Which I say, so I'm summarizing some of those points in words. Multiple studies show no improvement in overdose risk. with naltrexone compared to placebo. Some studies do, particularly the industry-sponsored studies, but other studies do, but multiple studies show no improvement, and as this study showing worse overdose risk compared to bup and methadone. And it's also much more expensive because it's still a brand name, and they're pushing it out on a lot of organizations, particularly sheriff's offices and criminal legal systems and drug courts. Are saying Vivitrol is the only way to go. And that's not what the science shows. The fourth treatment option is what we might call abstinence-based treatment. So this is a study that just came up like 2 years ago that did that comparison. Because if you look at this study, yeah, you're comparing medication, the light blue, and the dark blue is no medication. But no medication really is two different groups. You have no medication because you're not in treatment at all, and you have no medication because you're in treatment. It's just the people giving you treatment are not giving you medication, or you chose not to have medication. And so this study breaks that down. So you got your methadone and bup, which again are about equally effective at reducing the risk of overdose. But if you broke down the other group, abstinence-based treatment, meaning you're going to counseling, maybe you went to detox, maybe you had a bed somewhere for a few weeks and then you get discharged, but you didn't get methadone or buprenorphine. And then this fourth group is no treatment at all, which ostensibly means you're still using opioids in this. Basically, they found data in Connecticut, the state of Connecticut, over about a 2 or 3 year period. Anyone that overdosed and died, they look back 6 months to see what treatment or non-treatment did they get. And lo and behold, methadone and buprenorphine equally effective, but being in treatment with no meds was actually more dangerous than no treatment at all. And that's because abstinence-based treatment is a little bit like naltrexone in this previous graph. When you're in abstinence-based treatment, meaning no medication that stimulates the opioid receptor, you don't have a tolerance. And as I explained in the first half of this webinar series, or the last session, relapse is common. That just happens. I mean, just like it does with asthma and diabetes and heart disease, people lose control of their health issue, and then they get back to their doctor, get their prescription or whatever it is, get their insurance straightened out, their Medicaid gets turned back on, whatever it might be, and they get back in treatment. Relapse is common because it's a chronic medical condition. But when you relapse and you're not having had methadone or buprenorphine in your system, you have no tolerance, that relapse could be the last part of your story, to be frank. Whereas if you're using fentanyl every day, yeah, the last part of your story could be every time you use, but your body's used to it. And so there's less risk than if your body was not used to that. Dr. Shukla, I went to a webinar with Dr. Shukla, and he told me using drugs is safe. No, don't hear that. But it might be that continuing use of opioids is less risky than stopping use of opioids if you're not choosing methadone or buprenorphine. And that's how I counsel patients, that really methadone and buprenorphine is the best way if you're driving in a car to put that seatbelt on. I'm not planning for you to get in a car accident, nor am I planning for you to relapse, but stuff happens, so put your seatbelt on. And this is, I'm not going to read the slide because I think I should keep moving more quickly, but this is to point out, besides overdose, which in death I care the most about, there's a host of other positive outcomes related to methadone and buprenorphine treatment. In this case, reduces the risk of reincarceration if you have a history of criminal justice issues, less property crime most specifically, but less recidivism and probation violations, in addition to all that health benefit. So it's very good for health and communities and families, and for taxpayers who have to pay for jails and cops and courts and judges and lawyers. And yet, though the science is a slam dunk, not exaggerating, slam dunk, there's still around a lot of stigma, which is why we're doing these webinars, around MAT. Are we replacing one addiction for another? The answer is no, because the definition of addiction is not just that you develop a tolerance of the dependence, which these meds can cause, methadone and buprenorphine can cause. It's not just that. You got to have something from those other two categories, if you remember. So are we increasing or decreasing harm and risk? Well, whenever I see my patients with my methadone clinic, I'm asking them every day, are you feeling better or worse? If they came in and said, yeah, my toes are falling off, I would say, that's a weird side effect, but if it's related to your methadone, maybe we should not choose that path, right? So I'm being a doctor. I'm asking how things are going, doing tests, asking the right questions to determine, is this person healthier or less healthy? And then the third category, lack of control. Well, in methadone, we have the control because we give you a dose of the medicine for the day, and you come back the next day until you're developing your own control and then you're getting take homes, right? So it's not an addiction. Am I going to be on this medicine forever? I hear this with a lot of, blood pressure, diabetes medicine. Sure, no one wants to take medicine forever. The research shows as long as it's benefiting you, it's recommended you continue this medicine. It is safer to be on methadone for a long time than to be at risk of relapse. So if you're not at risk for relapse, that's a good time to think about, do you want to wean off? Because methadone does have chronic, effects over time, but it's definitely safer than the risk of fentanyl overdose. And that's proven in the research we just talked about. And buprenorphine actually doesn't even have a lot of those side effects of chronic opioid therapy anyway. And so very safe for long-term use. They're all just trying to get high. As I said, buprenorphine is not really a medication you can get intoxicated on. And methadone, again, we're controlling the dose. And it's also not great for getting intoxicated, particularly because fentanyl is so cheap and ubiquitous nowadays. So people usually are going to buy fentanyl if they're really trying to get intoxicated. This is just so, and maybe we have this data from North Carolina, I don't remember, but this is national data from 2022 of the big cut of all the people, adults who need opioid use disorder treatment in the US. And this is missing a whole lot of people who couldn't participate in this national survey, but the CDC estimates 10 million Americans in 2022, and it got worse after that, but a little better after that. But 10 million Americans needed opioid use disorder treatment. Of those, half received some kind of treatment, and half of those received medication, and the other half did not. So a quarter of people are on methadone or buprenorphine, and maybe a tiny bit on naltrexone. 30% are in counseling or detox or some treatment without medication, and another half are in no treatment at all. And most of those people don't think they need treatment because they're early in that whole time scale of recovery, right? They haven't recognized that there's a problem yet, even though it is a problem. But we have a lot of resources. North Carolina is rich. We are blessed that we are so rich in OTPs. Other states have a lot more rules and barriers to developing an OTP or having an OTP. So we have 97. I might already be out of date this slide, but 97 OTPs across 55 North Carolina counties. I'd say the far west, the far northeast, those are particularly places where you don't see so much action on this map. And so that's, the state is an awesome leadership and an awesome plan to increase access for those rural communities, but we're not there yet. We also have a variety of clinics, like I said, anyone can prescribe this. So this is not accounting for everyone, but this is a lot of clinics that can prescribe buprenorphine. This is the formerly incarcerated transitions program for North Carolina, and they have a map that covers most of the state. This is a program that uses community health workers with lived experience of incarceration to help connect people coming out of jails, coming out of prisons to clinics that prescribe buprenorphine. And there's a whole lot of clinics here that are mostly federally qualified health centers, so good places for people without insurance who are low income to get care. There's a variety of resources related to federal funding for these clinics. So we have great resources in North Carolina. We are blessed here. And then lastly, I'll just point out telehealth is a new thing for buprenorphine, not for methadone, for buprenorphine in the last 5-6 years because of the pandemic, but that is still a resource because the laws were extended to allow for telehealth. So, I was trying to be cute and put all these animations, but there's a variety of companies. I'm not trying to endorse a company, but I did want to put all these different companies. Some of these are North Carolina based. The rest are based elsewhere, but national. And there's a long list of them. I'm not endorsing any of them. Usually what they do is they do video visits at a certain syncope, and they send prescriptions to a local pharmacy. So you pick up your prescription, and you can do counseling and case management also through video. So not so helpful for those who don't have phones or have internet connection issues or whatever, but helpful for those rural communities where, if you do have internet. We do have some ongoing gaps, and I'm almost done here for if someone is chat boxing me to speed it up. There are not enough trained providers, despite we have a lot of coverage in the state. We need more, particularly in rural areas. And when I say trained providers, I mean trained in stigma, which is probably the hardest part because there's people who know how to do the pharmacology, but are still, I would say, treating our patients without enough respect and love. And I'll leave it at that. So not enough trained providers. Transportation, particularly for methadone, you still got to come, especially in the first couple of weeks, pretty frequently, if not daily. And so that is a barrier because folks who are pretty deep in their addiction sometimes don't have those resources, and public transports. North Carolina is not rich in public transport. Paying for care, our Medicaid, y'all, is at risk because of politicians who don't need to rely on Medicaid because they're rich. And that covers care for a lot of humans in North Carolina. Not to mention paying for insurance is harder and harder, as my bills of my family show. So paying for care is still a burden, but there are ways to get free care in North Carolina, which I can talk about in the Q&A. Housing and shelter, it's hard to take medicine when you don't even have a safe place to sleep in the next 24 hours. So sometimes what is the higher need, being out of the cold or the heat or the rain might be more important than trying to stop using fentanyl. So that's a gap. And then all these gaps are worse for all the same vulnerable communities: rural folks, racial and ethnic minorities, youth, pregnant and parenting women face very specific challenging circumstances, people involved in the criminal legal system, and people without housing. But we have solutions. I have solutions for everything, but I try to summarize it. We have tons of training programs, including through me and through the NC TAC for getting more providers. And then there's telehealth to improve access to those trained providers. For transportation, Medicaid can pay for transport. And then, of course, there's telehealth. And now methadone clinics can give take-homes pretty early for people who have difficulty getting to clinic. Paying for care, we did expand Medicaid, even though it's at risk, but we expanded Medicaid not too many years ago here in North Carolina. And hopefully the feds do not do away with the 1115 waiver, which allows jails to be able to pay for treatment. And then housing and shelter, there's some options, a lot of gaps there still, but there are some options depending on where you are in the state. I'll leave it there to see if anyone has questions, but please take note of my email address and feel free to send me fan mail. Thank you so much. And I don't know if we have a moderator or if I should just look at the Q&A or...
Yes. I'll help out, Dr. Shukla. Thank you so much. We did get a question in the chat. What about Sublocade?
I was muted. Great point. One is, it's newer. Sublocade is one version of injectable buprenorphine. And there's another company that makes a different version called Brixadi. Not endorsing any company. I just want to make sure people know the names. They're both pretty new products. They're still on patent, meaning they're still brand name. Medicaid pays for all these things, by the way. We have a great Medicaid program in North Carolina. But it's a bit newer, so the research is still newer. But the research so far is pretty much on par with the normal buprenorphine you take by mouth, putting it under your tongue, except you just have to take it less often. So it is a great option for folks, particularly if you're concerned about diversion or people just don't like to take something every day. It's a variety of reasons why it might be good for some people, why might not be good for some people, but it is a great option. It is different from the naltrexone, which is an injectable, totally different medication from the naltrexone. It is injectable buprenorphine. So great question.
Yeah, and please keep your questions coming in the chat, or you can use the Q&A tab. We did get another question in the chat that says, what is the reasoning behind the differences in all-cause mortality rates before incarceration, during incarceration, and after release from jail?
Great, and nice to see you, Jason. So I don't think I displayed before incarceration, but I don't even know if there's specific research about pre-incarceration, but we do know that acute or recent substance use is very common before the situation that will put someone into getting arrested. And that's because, right, like that's chaotic life. Using drugs is illegal. It would be a different story. It is a different story in other countries where drugs are regulated differently or drug use is regulated differently. But so I would say, yes, you're at higher risk probably of substance use and overdose prior to incarceration because that's sort of what led to incarceration. Then during incarceration, many jails do not provide treatment of any kind. And so people get very sick and they might say, well, that person had an agitated delirium or had a heart attack. And it might actually have been a suicide or an overdose, or they got so sick from withdrawal that they died. So the cause of death in jails is notoriously reported or analyzed wrongly. But because you're coming off drugs, that's dangerous. And once you're off it and you're having no cravings, for sure there are drugs in jails, and a lot of times staff has to do with how those drugs get into jails. And if you have no tolerance and get exposed to drugs, that is risky. And then you're in a jail cell where no one can help you if you need help. And they are used to ignoring folks sometimes. And so that can be problematic while you're in jail. And then post-release, again, you have no tolerance to the opioids, but now you're out in the world. You have a lot of trauma because being in jail is extremely traumatizing. Sexual assault alone is disgustingly common in jails and prisons. That's just one of the many traumas you might face in a jail or a prison. So you're out, you've experienced a lot of trauma, you got no ID, no housing, you got a probation officer that says you need an ID and housing and a job, but you don't have any of those things. Maybe you've lost contact with family, or maybe the family and friends you had were all people you use drugs with and you can't associate with them. And what are you going to do with yourself? And if you're feeling bad, you remember the cravings remind you of the thing that made you feel good when you felt bad. And then people relapse. But again, no tolerance means it's extra dangerous. And that's why there's such a high risk and high mortality post-release. And thus why the treatment is so effective, because decreasing somebody at high risk, you see a big decrease because there's a deeper fall to back to normal. So that's why it's 91%. Great question. Thank you, Jason.
And then, Dr. Shukla, what factors guide provider decision-making when selecting among MOUD options?
Great question. This is an experienced questioner. Let me summarize it in a soundbite. The rule of thumb in all of healthcare in America is informed consent and informed decision-making. I'm sorry, what am I trying to say? Informed consent and mutual decision-making. I'm saying the word wrong, but basically, jailer, you're my patient. I'm going to give you the options. I'm not going to tell you what to do. I'm going to give you the options that are based on science and best practice and guidelines, and tell you the pros and cons of each choice, and ask you what's important to you, jailer, like what's convenient, or is it about convenience? Is it about side effects? Is it about health issues you might have? Is it about mental health issues? I'm learning about you, teaching you about the meds and options, and trying to bring those together. Okay, based on your values, these are the choices. What do you choose? And you say, I want that. And then I'm like, is that in line with your values, right? And this is all healthcare decision-making should be in this way. And so you might choose something that I don't agree with. And I might even say, hey, Jayla, you chose the Vivitrol, but it sounds like in the past you've had a lot of withdrawal symptoms and cravings, and that was hard for you. And, being on the Vivitrol involves like going through withdrawal for a while, and you can't go to, I walk through it and I say, so that makes me a little worried for you, but is that still what you want? And you say, no, doc, I don't want to be on this or this. I want to be on that. And I say, it's your choice, because ultimately it is the patient's choice. I, as a doctor, am but a guide, not a gatekeeper. But, some kind of ways to think about that is buprenorphine is safer and more convenient, but methadone, you can sort of dose it higher, and has more of a controlled setting as the OTP. And so some people might be drawn in that direction or need this other direction. I would never guess for a person, because I've seen it go all the different ways, and people know their bodies and their lives better than I ever will.
Perfect. And then one final question we have in the chat. What about the role of community in sustained recovery? Is that important?
Oh, yes, absolutely. And I would say specifically a community of peers, people who know what you're going through and can give you non-judgmental, compassionate support and not make you feel bad for if you mess up or if you make what some might call a bad decision. That's really important, particularly early in treatments. That's like that first level. I'll go back. Oh, I'm not showing slides anymore. But that first pyramid I showed, that's where community support comes in through peer support. And then after that, the role of community in terms of resources for housing, resources for maybe mental health care, resources for jobs like vocational training, and continue to provide that community. That's important for a long while. But I think the problem here is that we often push on the community without the medication. And those are people who overdose and die without access to medication. And what I see in the healthcare system is, well, I guess that person wasn't just ready. They just weren't ready. They didn't make a good decision. And I think that's a bunch of malarkey, because I don't want to curse. So community, very important. But I don't think anyone disagrees that community is important. I think the problem here is that people have stigma not against community, but they have stigma against the medications. But great question and call out, Laura.
Perfect. I want to thank all of you for joining us for the second part. Right now we have a QR code. We have a post webinar survey. We'd love for you to provide feedback about topics you'd want to see in the future. We, of course, want to thank Dr. Shukla for joining us again for the second part. We also want to give a huge shout out to Angela and Heather for doing amazing interpretations during this. And thank you all for joining us. And we hope to see you in our next webinar. Details to come soon. But I hope you have a great Tuesday. Thank you all so much.
Bye-bye.